Hi there, Marius here with the Resuscitation Coach. In this video, we will review the PALS systematic approach based on the 2025 American Heart Association guidelines. I will post a link of the 2025 AHA guidelines in the description below. In the pediatric systematic approach, we will focus on evaluating a patient, identifying the presenting problem, and providing appropriate interventions. Once you have performed the interventions, you will repeat the process by re-evaluating the patient and identifying if the problem has resolved or worsened. Then you will apply additional interventions as appropriate. Throughout our PALS systematic approach, we will follow the evaluate, identify, and intervene sequence as we care for the sick or injured child. From the information gathered during our evaluation, identify the child's clinical condition by type and severity and start with the appropriate actions. So we'll constantly evaluate, identify, and intervene. Remember, if you identify a life-threatening condition, immediately intervene with your life-saving interventions. Let's begin with the initial assessment. When seconds count, your first impression can save a life. We use the Pediatric Assessment Triangle, or PAT, to make our initial assessment during our first quick from the doorway assessment. It only takes a few seconds but provides powerful information. It answers one key question: is the child sick or not sick? Here we focus on what we can see and hear before touching the child to help identify the general type of respiratory, circulatory, or neurological issues that will require urgent treatment. The initial assessment helps us to quickly identify life-threatening emergencies such as respiratory failure or cardiac arrest. If at any time we identify a life-threatening condition, we will immediately need to start intervening and activate our emergency response system. Let's break down the three components of the PAT and their relation as you walk into the room. Appearance. Here we assess the child's appearance, including the level of consciousness and ability to interact. Appearance reveals brain perfusion and overall tone. Use the TICKLES acronym to guide your observation. TICKLES stands for tone, interactiveness, consolability, look or gaze, and speech or cry. Tone. Does the child's muscle tone appear floppy or limp? Interactiveness. Is the child interacting with stimuli, parents, or staff? Consolability. Is the child fuzzy, even though the parent is trying to provide comfort? Look or gaze. Do the child's eyes track movement in the room? Speech or cry. Is the cry high-pitched or abnormal? Are spoken words slurred? Abnormal appearance may signal altered mental status due to neurologic or metabolic compromise, both of which can precede more obvious physical signs. Work of breathing. Here we focus on the work of breathing, position, and any audible breath sounds that we can hear. Keep in mind, this is without your stethoscope, like stridor, grunting, and wheezing. Here we also look at signs of absent or increased respiratory effort. Look for retractions, nasal flaring, and head bobbing. Increase the work of breathing usually indicates a respiratory distress. The child is compensating, but combined with abnormal appearance, it may point to respiratory failure, a much more serious and a life-threatening condition. Circulation color. Here we assess the child's overall circulatory status, assess the child's color, including the skin, and for obvious signs of bleeding. This section will provide us a valuable information about how well the child is perfusing. Look for pallor or paleness, mottling, which is irregular skin color on the face, arms and legs, or cyanosis on the lips and fingernails, a sign of inadequate oxygenation. Flushing can be a sign of distributive shock, or petechiae or purpura, which is bleeding under the skin, which can point us to possible sepsis. If the child is mottled, grey, pale, or cyanotic, immediately call for help and begin life-saving treatment. Circulation abnormalities alone may indicate compensated shock. The body is trying to maintain perfusion, but when paired with an altered appearance, that's a red flag for hypotensive shock. Here is how to put it all together. If the child has abnormal breathing only, think respiratory distress. If the child has abnormal breathing plus an altered appearance, think respiratory failure. If the child has only abnormal appearance, think central nervous system or metabolic causes. If the child has only abnormal circulation, think compensated shock. If the child has abnormal circulation and appearance, consider hypotensive shock. If all three are present, a life-threatening issue is present and immediate intervention is needed. This structured approach isn't just fast, it's life-saving. If there is no life-threatening condition, proceed with the primary assessment. The primary assessment uses a quick, hands-on A, B, C, D, E assessment, and you'll assess the child's airway, breathing, circulation, disability, exposure. As you proceed through each component of the primary assessment, treat life-threatening abnormalities in real time before you complete the remainder of the assessment. Let's start with airway and breathing. Ensure that the airway is opened, maintained, and protected. Breathing. Review the breathing rate, normal, fast, or slow. Review the breathing pattern. Review the oxygen saturation, and if it's below 94%, start oxygen. Check the respiratory effort and listen to the lungs for airway sounds. For breathing and airway assessment, use a stethoscope to listen to the following areas: the front of the chest, just to the left and right of the sternum, under each axilla and both sides of the back. A critical concept here is that a consistent respiratory rate below 10 or above 60 in a child of any age is often abnormal and warrants further assessment for potentially serious conditions. A tip here is to evaluate the respiratory rate before the hands-on assessment, as anxiety and agitation can increase the breathing rate. Also, bradypnea, or an irregular respiratory rate in an acutely ill infant or child, is an ominous clinical sign and often signals impending arrest. Let's discuss C. We need to evaluate the heart rate and rhythm, blood pressure, capillary refill, which should be 2 seconds or less, and central pulses, like the carotid or femoral in a child or brachial in an infant, and peripheral pulses such as the radial pulse. Weak central pulses are worrisome and might indicate the need for rapid intervention to prevent cardiac arrest. If the heart rate is less than 60 per minute with cardiopulmonary compromise, despite adequate oxygenation and ventilation, start CPR immediately. So what is the definition of hypotension by systolic blood pressure and age? For term neonates from birth to 28 days, you want to have at least a systolic reading of 60 millimeters mercury. For infants from 1 month to 12 months, it should be at least 70. For children 1 year of age to 10, it should be at least age times 2 plus 70. And for children 10 years of age and above, it should be at least 90 millimeters mercury. The blood pressure are based on the 5th percentile. The 5th percentile is a systolic blood pressure that is lower than all but 5% of normal children. Under D, perform a disability assessment to quickly evaluate neurologic function using one of several tools to evaluate responsiveness and level of consciousness. Perform the evaluation towards the end of the primary assessment and repeat it during the secondary assessment to monitor for changes in the child's neurologic status. Tools that we use include the AFBU mnemonic. AFBU stands for alert, voice, pain, and unresponsive. And a Glasgow Coma Scale or GCS. There is also a modified GCS for pre-verbal or non-verbal children. Two other quick assessments are pupillary response and glucose. For a pupil check, we use the acronym PALS, which stands for Pupils Equal Round Reactive to Light. Unequal pupils may suggest a serious problem, such as increased intracranial pressure or an eye injury. Normally, the pupils rapidly constrict in response to light. For any seriously ill child, obtain a point of care glucose as soon as possible to evaluate for the presence of hypoglycemia and hyperglycemia. Infants and children should have a blood glucose concentration of at least 3.3 millimoles per liter or 60 milligrams per deciliter, and for newborns should have at least 2.5 millimole per liter or 45 milligrams per deciliter. The final step of our primary assessment is exposure. This means monitoring the child's temperature and examining the skin for evidence of injury, bleeding, or rashes. It starts with a complete head-to-toe visual examination of the skin and the body, including the patient's back and perineal area. So we need to decide if it's a respiratory or shock case. If it's a respiratory case, we need to decide if it's respiratory distress or failure. And from there, it can be classified into one or more of the following types: upper airway obstruction, lower airway obstruction, lung tissue disease, and disordered control of breathing. Examples of upper airway obstruction could be a foreign body aspiration, anaphylaxis, and croup. Examples of lower airway obstruction can be asthma or bronchiolitis. Lung tissue disease involves the parenchyma or tissue of the lungs. Examples of disordered control of breathing includes disorders like seizures, central nervous system infection, and head injury, to name a few. For more information on respiratory disorders and treatments, please refer to your PALS manual. Shock is defined as a physiological state characterized by inadequate tissue perfusion to meet metabolic demand and tissue oxygenation. It is often, but not always, characterized by inadequate peripheral and end organ perfusion. A critical concept is that shock does not require the presence of hypotension. Shock can be present with a normal blood pressure or an increase or decrease systolic blood pressure. Compensated shock refers to a clinical state where signs of shock is present, but the blood pressure is in the normal range for age. Hypotensive shock, on the other hand, is shock or decompensated is characterized by evidence of impaired perfusion. The types of shock includes hypovolemic, caused by reduced intravascular volume due to things like diarrhea, vomiting, and bleeding. Distributive shock refers to a clinical state characterized by reduced SVR, leading to maldistribution of blood volume and blood flow. Examples could be septic shock, anaphylactic shock, and neurogenic shock. Obstructive shock refers to a condition that physically impairs blood flow by limiting venous return to the heart or limit the pumping of blood from the heart, resulting in decreased cardiac output. Causes include pericardial tamponade, tension pneumothorax, and a massive pulmonary embolism and ductal-dependent heart defects. Cardiogenic shock refers to reduced cardiac output secondary to abnormal cardiac function or pump failure, resulting in decreased systolic function and cardiac output. Common causes of cardiogenic shock include congenital heart disease, myocarditis, arrhythmias, and cardiomyopathy. Now we will perform an in-depth secondary assessment. We have provided a thorough physical examination. Now, as healthcare professionals with pediatric advanced life support skills, we need to gather additional information about the child and the incident that resulted in the need for medical care. Caregivers, primarily parents or other family members or babysitters, will generally provide most of the information. The sample mnemonic provides a memory aid to help us recall important medical information necessary to provide the best care for a young patient following a systematic approach. Signs and symptoms. A sign is something you can observe as a healthcare professional during a patient's assessment. A symptom is a problem or a complaint that a child or the child's caregiver reports to you. Allergies. Ask about allergies. Are there any known medication or food allergies? Medication. Ask about any medications, including over-the-counter medication, vitamins, and herbal supplements. Medications can provide important clues to the child's past medical history and current presentation. Past medical history. Past medical history includes the child's previous illness, hospitalizations, surgeries, and immunizations. And last meal. Ask about the last meal. Knowing when and what the child ate or drank is important. In cases like anaphylactic shock, what the child ingested may be the actual cause of the condition. And lastly, events. For events leading up to the presentation, we need an accurate timeline of all signs, symptoms, and events leading up to this moment. Small details sometimes make all the difference when it comes to taking the next step in treatment. Next, we need to perform a focused physical examination. Repeat the vital signs. Check for changes from the previous vitals taken during the primary assessment. Checking the vital signs is an ongoing evaluation. For our head-to-toe evaluation, we will start at head, ears, eyes, nose, and throat. Chest. We need to also look at the chest and consider the heart and lungs, and our outer chest. Abdomen, back and extremities, and neurologic function. Diagnostic assessments include further tests such as ABG, VBG, chest X-ray, and ECG, to name a few. We should always use a systematic approach when caring for a seriously ill or injured child, so that we can quickly recognize signs of respiratory distress, respiratory failure, and shock, and immediately provide life-saving interventions. If you benefited from this video, Kindly like, subscribe, and smash that notification bell, and we'll see you in the next review video. Have a fantastic day.